I'm Daina Sturnieks. I'm a falls researcher at NEURA and UNSW, and I sit on the management team for the network. So this session, please, take a seat and enjoy the last session. And I'd like to acknowledge the people who are joining by the live stream. This session is about providing the latest in research updates in fall prevention and bringing together what we've learnt today. At the end of the presentation, there'll be a panel session featuring all of our plenary speakers, so please have your questions ready. I'd like to now introduce Professor Cathie Sherrington. Cathie is a professor at the Sydney School of Public Health, University of Sydney. She leads a team of 28 people, the Physical Activity, Ageing and Disability Research stream within the Institute for Musculoskeletal Health, and she's a Deputy Director of that institute. Her research, if you didn't already know, focuses on promotion of physical activity and prevention of falls in older people and people with chronic disabling conditions. So Cathie will provide an update on the current evidence for fall prevention, interventions in hospital, community and aged care settings, and an overview of some important new studies. Thank you, Cathie.
Excellent. Thank you, Daina, and thanks everyone for staying around. So I'm going to take a slightly different approach this time because we had Jasmine's amazing evidence update on the basis of the guidelines. So I'm going to give a little bit of an update on data, a little bit on some new studies, including some ongoing studies, and then a little bit about implementation as well. So in terms of data, we really know that falls are still a major problem. And so these are the causes of injury deaths in Australia, the latest information from the Australian Institute of Health and Welfare. And these are the deaths by age in Australia, so for falls. So we can see that overwhelmingly it's to do with older people. And these are the hospitalisation data. So we can see younger people, are more likely, compared to deaths, there is hospitalisation for falls in younger people as well, but again dominated by older people. And then this is the proportion of older people in the population, and so this issue is not going away. And so in terms of what we know and some of the new research that's coming out, so this was actually the study from Daina and also Stephen Lord and many others, and this was the STEP, the exergaming approach, and this was presented at the forum here last year, but really wanted to highlight that it's now been published, and it was published in Nature Medicine, which is one of the really highest impact journals. Apparently Daina's a bit of a legend around UNSW circles now because of that. And so just highlighting that, really this approach to stepping, this sort of step game really did have a strong effect on falls, whereas the seated program had some effect but not as much. Another study that's been presented here before, which is now published, is the CHANGE trial from Anne Tiedemann, Iuliano, Oliveira and others. And so this was the phone coaching from a physiotherapist, which found that we could improve physical activity without increasing falls, and in fact found a non-significant reduction in falls, although in the people who'd fallen more previously there actually was a significant reduction. And the program was incredibly well received by participants, with various qualitative work published there as well. This is a new Cochrane review that looks at population-level interventions, so not so much the sort of smaller trials that we're more used to, but really the large population-level interventions, which there's actually more uncertainty about. So we really need to be actually doing some more kind of scaled-up research. Moving now to aged care, and so this was mentioned earlier, and this is by Jasmine, and so this is really quite transformative, as Jasmine mentioned, in understanding the role of falls, of exercise in falls prevention in residential care. And so basically this is the effect on falls at the end of the intervention, so straight after the intervention period, but then this is the effect on falls after people had had a period without the intervention. So really we do need to work out a way of actually continuing exercise in aged care settings. And those of you that were just in the residential care setting may have seen what I'm about to present, but just on as a warm-up to that. So Rick Dawson's PhD, as part of his PhD and with help from Sue Dyer and international colleagues, we were able to go back through all the trials that had been published in residential care and pull out in a qualitative way the trialists' perceptions about what was associated with more effective interventions. And this is an intervention components analysis, which we're also keen to do more of in other areas. And so that kind of pulled out, that figure shows the kind of key elements from the trialist perspective that were associated with greater effects. And then Rick took that in the very collaborative top-up study, really takes a village to do some of these complex studies with a lot of consultation, provider partnerships, and basically delivered a telehealth approach to physiotherapy with support from the care workers to support people to exercise. And here finding a significant improvement in the short physical performance battery, in fact a 2-point between group difference at 6 months, and finding a significant reduction in the proportion of people falling and a nearly significant impact on the number of people having falls. So it's really providing another option for delivering that ongoing exercise in this setting. And this is another new trial which we literally have just become aware of, which is actually a hospital trial, which is a stepped wedge trial which used a package of interventions. And it's really the type of interventions which kind of make a lot of sense and that people have been talking about. And in this Italian study, they actually were able to demonstrate an impact on falls from this sort of package of interventions in a hospital setting. More locally, we're doing another very collaborative study with Sydney Local Health District and seeing if we can apply some of the learnings from some of the work that was done in southwest Sydney, which we also learnt about first at this forum, and really a collaborative sort of coaching approach to support ward staff to be able to implement the Sydney Local Health District fall strategy. And that's Charlotte McClellan's PhD, who I think just presented in the hospital session as well. And as part of some preliminary work for that, she's really looked qualitatively and as so with interviews with I think over 50 health professionals, and really worked out that there's an issue with who's taking responsibility for falls prevention in our acute hospitals. Really the complexity and the staff not feeling supported, but there being potential for really working together to make a bigger difference. And this next one is actually from our invited speaker, and it was her visit which drew my attention to this. And so this is looking at, well, can we actually prevent falls in different populations? And so this was a study they did in the UK of the Boost intervention, which was a group-based physical and psychological support intervention for people with spinal canal stenosis. And as well as improving walking, they actually prevented falls. And Sallie's giving a talk about that next week. That was a little heads up. Interestingly, so a few other talks I've heard that people in other areas are starting to talk more about frailty and falls. And in fact, this is a position statement from the American Heart Association, a very powerful group, talking about the importance of falls in people with cardiovascular disease. So I think that's a space to really watch in the future and to try and get involved in as well. And so now just a little bit about some recent things or things that I've recently become aware of that might help us to implement some of this evidence. And so this is an update of the Consolidated Framework for Implementation Research, which really helps us kind of articulate the complexity of changing practice in the real world. So it talks about the characteristics of interventions, but also of implementation strategies, so how we might support those interventions, as well as the context, so both the inner context in the sort of the local area and the broader context, so the outer setting, and that's where sort of policy and funding is so crucial as well. And then just a reminder about the initiative last year, so this call for action, so really talking about why we need to invest in falls prevention nationally. And as a sort of follow-on to that, a few of us worked on a sort of academic piece of work which was looking at an analysis of the current policy context and really confirmed that there is no national falls prevention policy, but that falls were mentioned in, I think, 9 other documents, and also highlighting really the complexity from a public health point of view, the sort of earlier impacts that might be contributing to falls, and that's where the equity issues kind of really come in as well. And then the New South Wales white paper that's been mentioned already as well. So I believe there's some high-level discussions going on about that, but nothing concrete as yet. And then, as we've heard this morning, looking out for the update of those national fall prevention guidelines, which we're hoping for by October. And I just spotted these new American guidelines, so the US Preventive Services Task Force about falls prevention. They focus on exercise. Interestingly, they still only talk about exercise for high-risk people, whereas our interpretation of the evidence really is that exercise should be delivered across the population. And they also talk about the multifactorial approaches in clinical settings as well. And this is, as you can see, a picture of an elephant. And this is really, it was actually Stephen Lord who presented this a few years ago, and it really struck me. So it's to do with the parable of the blind men and the elephant. And so people are feeling an elephant, so different parts of the elephant, and they're coming up with quite different conclusions about what an elephant actually is and what it looks like. And so I think this is a little bit relevant in this area, because with the ongoing problem of ageing, of inactivity, of loss of independence, of frailty, of osteoporosis, of pain, we're getting a lot of people advocating and a lot of people sort of talking about these issues, but not necessarily always being on the same page. And so I think we can learn from that, and we can try and engage more with other groups who are also doing advocacy in this area. And one thing that I think might be useful is to sort of try and think a little bit more about frailty and how frailty might connect with falls. And so this is the clinical frailty scale, which is really being used in a lot of parts of our health systems. And I think that can be useful in kind of describing our fall prevention interventions and describing sort of who we're targeting with different interventions. And then this is something that I just picked up from the Rehabilitation Medicine Conference this week, where one of the speakers had done this. And so he is obviously an older woman, who may well be frail. We can see, she's obviously a little bit older. We don't have much information, but then when we get information, we can see that she's actually just finished a marathon, and in fact she's holding the record for the women's marathon in the older age groups in Australia. And so that sort of comes really, I think, to the diversity of ageing and really the importance of considering frailty and physical function when we're talking about older people. And so with some work that was also just presented in the community session, Vanessa Kwok, working with the longitudinal study of women's health, has actually looked at the relationship between physical activity and falls. And this was actually Vasi Naganathan's idea because of the, how much frailty is being talked about in other circles, as basically finding that, at least cross-sectionally, promoting physical activity may be problematic in people with frailty. In fact, the people who were frailer or had mobility impairments, the people who did more physical activity actually had more falls, whereas in the people without frailty or mobility impairment, it was in the other direction. And so I think that's where, coming to our interventions, which we know prevent falls, but are more complex than just suggesting that people be more active. And also with understanding what's happening in other fields, this is a recent major systematic review that's come out in the BMJ, which looks at interventions for maintaining independence in older people and basically finding impacts of kind of multifactorial interventions, many of which included exercise as well. Another thing that's come out recently, so this was in the MJA, and this was some modelling which looks at the cost effectiveness of different approaches for addressing osteoporosis at a population level. And again, that's something that we've been starting to engage with, and this is on behalf of our Falls Prevention Centre of Research Excellence. Marina Pinero has actually done a systematic review about the cost effectiveness of fall prevention exercise and is going to be taking that next step using similar models to what was done in that osteoporosis paper. So, in summary, in terms of data, falls are still a very big problem in Australia and indeed around the world. In the community, we can see that stepping and exergaming definitely can prevent falls. That phone coaching can enhance physical activity without increasing falls. In residential care, people need to keep exercising, and that telehealth physio might be able to help that. In hospitals, there are starting to be some promising movements with intervention packages and the understanding really of supporting staff. In clinical populations, there is, falls can be prevented in people with spinal canal stenosis, and that in terms of implementation, sort of new models might be able to help. The American guidelines have been released, Australian ones are on the way, but we still don't have a national policy on falls in Australia, or indeed a New South Wales one, and the drivers are complex, but also if we're better able to engage with other perspectives and other advocacy, that might help us gain further traction. And thank you very much. But we're just going to play a little video, and again from something that we can learn from other places. This is something that they're doing in Western Australia, and it'd be interesting to see what people think of this. So they've actually launched a campaign. Don't take a fall. You looked out for a mate, even fell your day. Well, you cost a lot of debts, but there's ways you can prevent another injury from ruining your day. Now you've got to keep moving, always improving and removing everything that's in your way. Just remember to move, improve, remove. Excellent. And that's all I had. I believe we're going on to a panel discussion. Thank you for your attention.
Thank you, Cathie. Not before we have some questions for you.
Oh, okay.
At least
I thought it was built in. Yeah.
Okay. A couple of questions for Cathie if we have them. And of course, extra questions can be asked to all of the panel members in just a moment. Excuse me. Those online, if you've got some questions, please submit those. Anyone in the room? Have we got roving mics? Our mic rovers have retired for the day, perhaps. You can shout them out. There is some questions online. Cathie, if you want to pick up on one of those, please do, otherwise. That might have been from earlier on.
That's oh, do you think is that from early on?
No, maybe go for it. Maybe not. Maybe they're from earlier on.
Okay. Yeah, well, I will address them anyway while we're waiting. Yeah, someone asked if there was a community nurse-led fall prevention program that's been successful. Not actually to my knowledge, but yeah, that's certainly something that does require further investigation. And then there was a lovely comment about Megan's talk about the history of stepping on, which would be also great to have again. I think it might have got a bit cut short with coming to the main session.
There's another question there that might be answered by you, Cathie, and congratulations on identifying all these other sort of organisations who might have common interests and so that we could work together. But there's a question there, given the importance of allied health fall interventions in aged care, how can we lobby better towards direct funding by the current ACC model?
Yeah, that's a very good question. And I think, again, really collaboration comes to that bringing different voices together to, really highlight the evidence and really the equity issues in that.
No further questions for Cathie? Well, if you do think of them, you can ask her in just a moment because I think she's going to take a seat there. But before you do, thank you so much for your presentation today, the update of the evidence. So now if all the speakers can come up and have a seat. I think it's been an excellent day of talks. I hope you've all enjoyed it as much as I have, with some really interesting insights from various experts and areas of research. Is there a question in the audience already, Stephen? Good. Okay, go ahead.
My question was just, is there someone here from southwestern Sydney? Because we've heard it from all different parts of Australia, but I didn't hear any talks from there.
Anyone in the room from southwestern Sydney? 2, 3, 4, 5? There's a few hands going up. But we didn't have any talks necessarily from these people, so we'd maybe encourage you to submit your ideas for talks at the next forum, because we'd love to hear from you. And I think, I guess we do have a lot of evidence coming from Australia and from other developed countries where the evidence is coming from a very distinct group of people. And the point was made earlier about how we can use that information in other populations, not just within Australia, but around the world as well. So we do need to keep in mind our multicultural population in New South Wales and Australia, as well as understanding how we can prevent falls in other countries. Does anyone want to talk about diversity in our evidence base? Sallie? Yeah, just look it up. Yeah.
Yep, this is something that we talked a little bit about at a conference that we've just finished up with some rehabilitation physicians, and I think it is it's quite a challenge trying to fund research. It's very expensive across the world, and what we notice, there's about 25 countries that have contributed to the research evidence base. Most often in the field of exercise, I think it's possibly a little easier to implement. But we do see a very significant clustering around 6 parts of the world. They kind of cluster into Europe, North America, and Australia and New Zealand. So certainly, I know within our own countries we have to think about diversity. We also need to think about how we encourage our colleagues working in very often much more resource poor settings, and also settings which have a very different quite often very different cultural approach to exercise, very different environmental hazards to deal with. So I think you probably have a wonderful opportunity in Australia to be able to collaborate with people from across the world. You have so many people from across the world living here, so you have a kind of step forward to begin with. But I would really hope that perhaps Australia can lead in worldwide collaboration. We're certainly trying from the UK, so we're working with people from Indonesia at the moment, and it's a very different set of challenges that they face in trying to raise the profile of falls and to implement and engage their populations with that.
Guess I'd just add, I think it is increasingly important to better describe the populations in trials, so absolutely, I think that, but some of these things might come to implementation as well, and really the kind of mixture perhaps in a lot of the falls trials of really if it is looking at the effectiveness of interventions or the challenges with actually implementing the interventions in different settings. And so I think now that field sort of moving further, we can perhaps do a better job of trying to tease that out in the falls trials as well.
So Cathie, on implementation, I've always seen it as the research that we do, we're very, we're okay at getting funded for doing very controlled trials. And then we get this evidence and we'd like to take it out to the community or wherever the setting is. But we don't seem to have those funding opportunities to do that work. Do you think that that's changing?
I think that it is, but then the other thing I think that sometimes trials get a bad name with sort of thinking that they're very controlled, because like a lot of trials really are in the real world. I mean, Sandra's trial is a perfect example of that. That's not a trial that's done like within a laboratory. That's really engaging with the real world, and which is complex. So yeah, I think there's not necessarily a clear distinction.
So, yeah, good point. But then I guess scaling up Sandra's evidence. Sandra, do you want to comment on where you are at and, have you had any luck in scaling up your work?
There's a question down there, how many policy makers attended today? They're the people you need to talk to get change happening. I'm lucky I'm in a position where I can present evidence to them. So one of the ways is, the trial is the trial, and I've been putting it under the nose of government to sort of say, look, this is it, it's cost saving, all those things. The biggest driver, there's two drivers. One, at the site, how much is it going to cost me? Two, for the policymakers, how much will it save me? So the health economic analyses are critical because they'll only pick it up if they see that there is a financial benefit, which is the driver, unfortunately. With our particular work, I got funding to develop a training program that actually teaches them to do what we did in our trial. And the goal of that is eventually any chef in any location in Australia can actually go through the process and implement it. Because it's not difficult, but the key for success is it has to be individualised. You have to, if not, I'd have had a book, I'd have just painted it and made money out of it. It's about who are your residents, what do they want to eat, who is the chef, how can they cook, what are your facilities. So it's very much about resourcing them to empower them to do it themselves. And I think that's the only way we're ever going to get it across the line.
I have to say I was pretty... I don't quite understand why perhaps your media hasn't picked up. I mean, it's pretty much a national scandal. Oh, they did, good. I was going to say, I mean, it's a scandal, really. So how much did they pick up? How long did that last for?
I had my 15 minutes of fame. The good thing was it was picked up nationally and internationally, and it did get mainstream media, which is really critical. Plus it got all the online stuff, but it did have, Channel 10, Channel 9, those big stations, which a lot of these demographics are watching. So it did. The good thing is it's allowed me to speak more internationally than nationally on policies and things like that. So that kind of coverage does give you a little bit of a voice. As long as you use it, like the purpose of it is to better the lives of people in aged care.
I had a question for Sallie. So she mentioned in passing the other day that in the UK there's actually more funding schemes that kind of support translation activities, whereas we don't actually have that here. So, when we've done the trial, that's it. Any translation activities are normally, off the side of our desks.
And before we go to Rick, I wanted to ask Sandra, so I was interested to know who did fund that extra work in the training? Where do you get that funding? Where do you find it?
Two things. One is The original project, as you saw, had 7 dairy research foundations from all over the world, had the literally dribs and drabs from everyone. This second load of funding is NHMRC, but they're not funding the project. I actually got a commercialisation grant from the Victorian State Government to actually produce the training so that it can be implemented. So you've sort of got to scrounge around a little bit to get the money.
Well done, excellent. Okay, we've got a question from Rick in the audience.
My question, in Australia, every political jurisdiction says falls is not my problem. Aged care says it's hospitals, hospital says it's federal care. Other jurisdictions like UK have a national model of care, one system for all their people, but there seems to be that falls doesn't get the traction and that everyone's putting their heads in the sands around this ageing problem while other clinical issues that have less impact economically get more attention and more money. I'd like to ask the panel, what do we do about creating this more social awareness about getting older and being more well as we age?
Now, it's a challenging question. To quote Lorraine in one of our copyrights, fall prevention is everybody's business. So that's really the answer. All aspects need to be involved. It's across government. It's not just the Department of Health and so on. So that's one of the issues we've had with our white paper. Another issue that is an interesting one, it's not a disease. So if it were a disease, it would be owned by medicine a lot more. So it is, it's a multifunctional issue, and it is everybody's business, and it's actions like, I think, the white paper to try and get, cross-government support to try and address it more seriously. But you asked a tough one.
Yeah, I would also say one of the difficulties is, and I don't want us to change this as it's not a disease, so much of our primary care in the UK is focused on disease management. So it does make it difficult. But I do wonder if we were to promote more of the positives, so really keeping people mobile, keeping people fit and active through a variety of routes. I mean, there's a whole heap of things that we need to think about, like I don't know how you're managing here, but we've just got really bad access to joint replacement and what have you. These are things that are large-scale interventions that retain people's mobility, and maybe if we were able to cluster together interventions that achieve a large outcome like that, it may be a way forward for us, but who knows, it may not be.
I think there's another question up the back there, thanks.
Yeah, good afternoon. This is my first time attending, so all the talks have been massively interesting and new and amazing, but you guys have been experts in the field for years. What research being presented next year would knock you off your seat and be like, wow, this is what we need in fall prevention, this is what's been missing, if any?
Well, great question. I think it's a little bit like, what are we going to do, before we retire? And, are we going to get to that 50%, that 60% clearly replicable intervention that really works so well? If you look at what we've seen presented today, we've seen all these various aspects that contribute, at least in exercise, to fall prevention, from reactive step training, voluntary step training, balance transfers. If we looked at PD Warrior and what it contains, it's a lot of different evidence-based strategies all put into the one program. We haven't got there yet. I mean, maybe that's one of the interventions to come, something that really encompasses what we do in everyday life that's really task-specific, that addresses many of the things we do, from being able to react quickly if we're knocked off balance, to undertake transfers. Maybe, if that sort of intervention was put in place, we could get to the 50% plus figure, and I think we'd be all knocked off our seats for that one.
Looking forward to that.
Yeah, there have been a few game changers in the last couple of years, not in our field. A real game changer has been Ozempic, when you look at kind of weight management and all of the difficulties that people have had to experience in managing their weight, or, kind of managing food intake, exercise, a lot of intervention. So you never know, one day there may be a game changer pill And I'm not a gym bunny, so I would be the first one to say it's a game-changing pill. But I honestly can't see it on the horizon.
I was thinking in terms of also falls detection. We've been talking for a long time about a really good sensor that would detect falls in the real life, but nothing yet seems to have come out. So I think if there was one, and I think from your talk, Sallie, this morning, yeah, it's on its way. But I think that would be really good.
So I'm the sort of more from the population health and implementation point of view. So what would really knock my socks off would be if we could actually have a population level intervention that had a kind of clear approach to targeting different interventions for different types of people, and supporting the delivery of those, and also supporting people to change their behaviour.
If I can just add to that, you've just asked a podiatrist what would knock his socks off. So I feel like I need to respond to that.
On slip socks.
That's right. What would really knock my socks off would be sustainability of an intervention. So even if someone presented a randomised controlled trial that reduced falls by 50%, that would be impressive, but what would impress me more would be if that was something that could be sustained for a long period of time, because what we tend to find is that a lot of these trials, because they're only funded for a certain period of time, people only do the intervention for that period of time and then it drops away. So I'd be really impressed if we could actually get a sustained reduction in falls.
Okay, a question from the room.
A game changer that has been announced very recently, and I noticed that and I've heard wonderful talks about doing something about Parkinson's disease. Just recently, they've announced that Parkinson's disease starts in the gut, and using the microbiome, with the good guys in the stomach coming out with the right amount of, connecting up with Parkinson's disease is the first announced, but there's a whole lot of other things, cancer, all those things start in the gut. We need to do more about where that as one of the talks was about a river that's coming down. Well, right at the top of the river, the start is do more about the microbiome. Thank you.
Natalie, do you want to address that one with the PD question?
Yeah, so there has been some research lately that has suggested that at least for some people with Parkinson's disease, that it starts in the gut. So there's a strong school of thought with Parkinson's disease that it's not just one condition, that it's actually Parkinson's diseases. And they present similarly, but there's still a lot of diversity amongst what happens with people with Parkinson's disease and the way that their condition progresses. So for some people it appears that the degeneration starts in the gut and then spreads up to the brain, and for other people it starts in the brain and then spreads down and involves the gut as well. I think there's a lot of work into the future looking at what the implications of that might be in terms of how to manage and hopefully one day cure Parkinson's disease. But for the time being, I think whether it starts in the gut or in the brain, I think exercise has such a broad reaching kind of mechanism that it affects the entire body. And so regardless of sort of what little biological pathway might be happening, I think exercise and physical activity are always going to be really good interventions to try and help improve people's health, well-being and reduce falls, because it is more of a broad sort of mechanism.
Thank you. We've only got one more minute, and because I'm owning the microphone, I get to have the last question. Thanks for the work that's been done in the world and the Australian Falls Guidelines. It's great to see them today. It's great to hear them talked about. And as a researcher, I love to see the evidence distilled like this. How do we think they will best be used? It's just just wondering, will they best be used by clinicians, policymakers, everyone? What do we think their value is most significantly? Anyone want to take?
No, I can give it a try. I think how we, so we've been producing these guidelines together with the Australian Commission on Safety and Quality in Healthcare, and the view has been to write them in a way that they can actually be used by a variety of, a diversity of people, so clinicians, aged care providers, allied health practitioners, anyone, any health workers, any researchers involved in falls prevention, so any health person involved in falls prevention, I think, and that's where we've been really being very careful with the language we use to try to make sure it applies to everyone. So I think it will be to a very broad range of people, depending on the setting as well.
Thank you.
The last word on advocacy, because having the evidence summarised, I think is potentially a really powerful advocacy tool.
Oh, advocacy, yeah. Excellent. Well, thank you very much. Thank you to all our invited speakers and for coming back up onto the panel. Thank you for all your questions. Sorry we didn't get to them all. And the people online who've submitted questions, what we're going to try and do is get some answers to your questions and distribute them to the network and this group here. So thank you very much. I'm going to hand now to Stephen Lord and Lorraine Lovett to finish up in the last 10 minutes. Thanks very much.
Can I just remind you the QR code's been put up for evaluation. Would you mind now just taking a few moments to plug into that and give us some feedback? Like we say each year, it's really important for us to hear back from you so that we can tailor the next forum and other things that we might want to send out through the network to support you as well. So I think that's a really important thing. And one other thing as well, when you do leave, there's a box outside on the table. Would you mind just popping your name tags into the box? Thank you. Back to you, Stephen.
Yeah, well, the final thing to do is, you'll probably notice this meeting today went seamlessly. It was very smooth, all really well done. And you might not have noticed the person behind it all, Stephen Fu, who's our falls coordinator position, who does everything so calmly, so smoothly, that everything seems to work like clockwork. So we're really thankful for how it's all worked today, and if you'd like to come up, we just have a small gift for you. Yeah, so thanks very much, Stephen. It was fantastic. All right, so I think...
Are we finished?
I think we're all finished. So thanks everybody for coming. It's been another wonderful time. And got any final words?
Yes, go well, stay strong, and please enjoy your long weekend. Stay safe as you travel home or to wherever you're travelling to. And please remember that you are our voice and you are our future and leading the work, and please be encouraged that there's little things that you can do that can make a difference. So thank you for your participation today. It's been great.
Till next time.